So without further ado, I will introduce the first speaker. So what we're going to have is a presentation from Roger, and I will just take a couple of questions after that, and then I'm going to get all the panel members up, of which we've got 5, and they are only going to speak for 5 minutes max. I'm going to be a harsh timekeeper. 5 minutes max. I'm eyeing them around the room. Okay. Roger, I'll get you to come up. So it's Roger Lewis, and he's going to speak about informing ethical evaluation of adaptive clinical trials through simulation. A big hand, I think, for Roger. Post-lunch slot.
Yeah. Great, thank you very much. It's a pleasure to be here. What I'm going to do is try to talk about methods that we can use to evaluate options in clinical trial designs to inform choices made by investigators, choices made by regulators, and choices made by those who fund research. These are my disclosures. The most important one is that I do work closely with Berry Consultants, and then there's some other federal and other relationships. And I'm going to present some work that was done by a number of other statisticians, especially Kurt Bialy, and Alex London, whose name already came up, has had some important influence on the work. And if you ask the right question afterwards, I can bring up some slides that I had to cut out for time. So the Institute of Medicine in the United States, now called the National Academy of Medicine, issued a report where they looked retrospectively at the research activities around the recent Ebola epidemic in West Africa. And one of the primary recommendations from that committee was that randomized trials are the preferable approach. Unless there is a compelling reason not to do so, every effort should be made to implement randomized trial designs. So what I'm going to talk about today is options within the space of randomized trial designs and how we can use simulation to help us make informed decisions that reflect the values of the participants in the trials and those implementing the trials. So you already heard on the first day from Scott a discussion of a really quite elegant adaptive trial, but I want to go back a little bit and talk about why we do adaptive trials. When we design clinical trials, we know very little about what's going to happen with respect to enrollment, patient characteristics, event rates, and the efficacies of the treatments that we are investigating. That lack of information and that uncertainty creates uncertainty in what the best trial design is. What's the right number of arms, the right number of patients, those sorts of things. And yet, traditionally, we make our best guesses or we make incredibly optimistic assumptions regarding those same characteristics. We design a trial and we just run it to the end and see how it turns out. And that strategy, which is completely blind to the information that accrues during the trial, can lead to an increased risk of a negative or a failed trial, where a failed trial is one in which at the end of the day, you're not really sure what the answer is to the question that motivated the trial. This approach also can cause us to miss an opportunity to use incoming information to treat patients more effectively within the trial, and we'll come back to that in some detail. So the advantage of an adaptive trial is that once patients are enrolled and partial information starts to come in, that information is incomplete. It can often have missing data or errors before it's carefully checked. We start to know something more about those very things that we had to make guesses about before we started the trial. An adaptive trial, when designed properly, is designed to take advantage of that incoming stream of partial information in order to do something better than if you didn't have that information, and to do that according to completely pre-specified rules. So these are rigorous pre-specified trial designs, which means they can be simulated in computers, and you can understand all the statistical characteristics that you find of interest. So in some circumstances, and we'll talk about which circumstances, this approach can increase the chance of getting the right answer, meaning identifying a treatment that works when it does, figuring out that a treatment doesn't work when it doesn't, or treating patients more effectively within the trial itself. Any adaptive trial can be put into this general framework. At the beginning of the trial in the upper left, there's no information yet available to learn from. So we start a trial in a very traditional way with balanced randomization between groups, or perhaps exploring only the doses for which we have adequate safety data. At some point, we have some available data to analyze, and we ask ourselves, is there a good reason to stop the trial, perhaps for futility or because of a safety concern? And if there is not a good reason to stop, then we take that evaluable information and we revise something about the trial, or we decide to leave it the same. So we may change the number of arms, the randomization allocation between doses, or some other feature like the qualification characteristics for the patients. We continue this in a circular fashion until we meet one of the pre-specified reasons for stopping the trial. For example, we have a clear answer to the question at hand, or we reach the maximum planned sample size. The art, if you want to call it art, of clinical trial design is choosing what rules should be built into that bottommost box so that we do something smart and helpful and ethical with that partial information. And there's lots of things we could do. We can change the sample size so that we make sure we don't run a trial that's either too small or too large. We can do response adaptive randomization, where we allocate patients as they come in based on how good the arms seem to be performing based on the initial partial data. And we can have early stopping for futility or success or for harm. We can have enrichment designs where we change the enrollment criteria. I'm going to focus on response adaptive randomization to illustrate the power of simulation to inform decisions regarding design choices. So here is a typical response adaptive randomization strategy. In this case, where we have a control arm and we have 3 different experimental treatments that we'd like to evaluate. During the burn-in period, during which we have no information yet available, we just do balanced randomization. But starting at the first interim look, which is the first vertical red line, we change the randomization proportions according to the probability that each one of the experimental arms is the best of the experimental arms. And in this hypothetical example, as time goes on, the second drug, or the experimental arm number 2, is performing better and over time becomes the most common experimental arm. And there may be even a point at which it becomes the only experimental arm surviving, and you have a trial that basically randomizes between the arm that turned out to be the best and the control, even though you didn't know which arm that was going to be when you started the trial. There are some very important characteristics of this picture that I want to point out. The first is that there's more than 2 arms. So there's more than 2 experimental arms. This is really important. That's not greater than or equal. It's greater than 2 arms, so 3 or more. That's important because the best trial design is very dependent on the number of arms being investigated. The second is that there's an adequate period of burn-in. We don't start responding to partial data until there's enough partial data so it's worth responding to. And then the third is that you may notice that the gray control arm bar has the same width throughout. You don't want to randomize too quickly away from the control arm, because if you do so, you can make yourself vulnerable to biases associated with changes in secular trends over time or some other problems. So one of the important things about evaluating a trial design is making sure that whatever strategy you're incorporating, you're doing it in a way that is thoughtful and is tested. This partially addresses the therapeutic misconception in the sense that the patients who are enrolled later in the trial have their allocation partially informed by the information acquired earlier in the trial, and that increases on average the chance that patients enrolled later will receive a therapy that is in fact effective for them. It doesn't completely address it because, of course, patients continue to be randomized to the control arm, and even when you have partial information partway through, you could still be randomized to an arm that is the lesser of the experimental arms in terms of the performance at that point. And there was a question asked specifically about that yesterday. Now, how is it that we can decide whether this approach makes sense, whether it has good characteristics in terms of its scientific validity and good ethical balance in terms of the risk and benefits to patients? The way we do that is to run the trial thousands and thousands of times in simulation under a wide variety of assumed different situations regarding what the truth is. The truth may be that none of the arms work, one of the arms work, one of them is harmful and one is beneficial. The patient enrollment will be fast, it will be slow. And the goal in trial design, when it's based on simulation, is to design a trial that does something that's scientifically valid and ethical, regardless of what the truth turns out to be. And all too often, we design trials that only do things that are reasonable if the null hypothesis is true and nothing works, or the overly optimistic alternative hypothesis turns out to be true. And that's a very narrow group of situations in which we want to design a trial. So there are lots of potential concerns that could be raised by these kinds of approaches because they violate a lot of what we had been taught in beginning statistics classes about the importance of having fixed trial designs. People worry about multiple looks and inflation of type 1 error, bias or in the estimation of treatment effects, loss of precision in estimation of treatment effects, especially for arms that don't end up with very many patients on them, problems in the accuracy of identifying the best arm, or an exaggeration of the benefit to patients within the trial. For each of these concerns, there is a very clear solution, and that is to simulate the trial and understand actually how it performs. A colleague of ours says that you should, the first time you run a trial, it should never be with real people. So you want to run it many, many times and see how much bias there is, how often it gets the wrong answer, what the power is. And in fact, for each of these, the solution is exactly the same. Figure out what it is you're worried about in terms of the threat to validity, quantify it through simulation, and then you understand that threat, and you can make an informed decision regarding the selection of the trial design. The goal, after all, is to hurt as few people as you can in getting information regarding relative treatment efficacy. The irony here is that the New Yorker cartoonist thought that being in the placebo group is bad. I would always prefer to be in the placebo group. You get great medical care and attention and no risk, but that's just me. Okay. Now, in the second part of this, I'd like to talk about how our behavior reveals our underlying values. So ideally, we would decide what the goals are of a clinical investigation, what are the risks that we're willing to occur, what are the expected benefits. And those goals and priorities and the values of the patient populations we serve would inform our trial choices. But in fact, all too often, what really happens is that we have very strong preconceived notions regarding what kinds of trials we want to run. And in fact, it's those choices that tell us what our values seem to be, even if they aren't the values that we really would claim publicly. So for example, I took some text out of the background paper, which says that the response adaptive randomization scheme, similar to the one I showed in the diagram, implies that more participants enrolled in later stages of the trial will have a higher probability of being allocated to the better treatment, and this raises ethical concerns about justice and fair participant selection. That phrase seems to imply that the goal is to provide equal access to the lesser performing arm, even once we start to have a clue which one that is. Now, that may be a goal, but it doesn't sound like a goal that we would have set out a priori. So let's talk about the kinds of goals people have in clinical trials. There are goals which I've labeled as investigator-centered goals that have to do with the ease of research implementation, so the use of commonly accepted or standard methods, least burdensome methods in terms of acquiring funding, ethics review, local messaging, regulatory review, and peer review. There may be statistical goals, such as unbiased estimates of treatment effects, rapid or efficient estimation of treatment effects in all arms, even ones that we end up not thinking are very good, accurate or efficient selection of the best non-inferior arm, or getting the right answer overall, meaning a positive result when the treatment works and a negative result when it doesn't. And then there may be patient-centered goals, such as accurate selection of the treatment for use beyond the trial, better treatment of patients within the trial, or efficient evaluation of multiple treatments or combinations of treatments when we're in a space in which there are multiple things that we want to sift through as quickly as possible to find the best combination. And I've put some numbers and letters here to illustrate the ordering of these that, in fact, is often what I see when I'm talking with clinicians regarding clinical trial design. So let's talk about what these priorities imply. So for use of commonly accepted methods that are least burdensome, these are things like non- or minimally adaptive trials, two-arm, one-to-one randomized RCTs, or single-arm trials with historical controls when that's what's ethically acceptable. Getting unbiased estimates of treatment effects means you want to avoid early stopping for success because it introduces some bias. And if we really want equal precision in estimating the effect of all arms, even ones that aren't very good, we have to continue to allocate patients to those arms that aren't very good. So these choices that we make, and commonly continue to make, imply that our priorities are those investigator-centered or those initial statistical goals. So let's now examine those goals through simulation. So for a simple example, let's consider a case where you have 4 experimental arms and 1 control arm, and the numbers in the table are the truth regarding the the survival rates in each of the arms. So in the null scenario, none of the treatments works, and 30% have a good outcome. In the mixed scenario, everything is better than control, and they have different efficacies. In the so-called Nugget scenario, only one of the arms is better than the control arm. And in fact, in both of the cases, other than the null, arm 4 is the one you hope the trial selects as the best result. And let's suppose we want to compare 2 design choices. One design choice is a fixed randomization trial where you have 2 patients allocated control for every 1 patient on each of the 4 arms. And we're going to do that versus a trial that uses response adaptive randomization, so it shifts the randomization towards the arm that appears to be performing better. It has the characteristic that there's a fixed allocation to control. It has the 2 options have the same sample size, and they've been tailored to have the same type 1 error rate, the same level of statistical significance. And let's compare the power of the trial, which is related to the importance of getting the right answer, finding the best arm, which is closely related to the goal of treating patients well after the trial, and how well we treat patients within the trial. And we can do that because we're going to simulate this. And this is the kind of results you get. With the fixed design, the power is 71%. So 71% of the time, you will figure out that one of the arms is better than the control. The chance of getting the right arm, which is arm 4, is less than 1/2 with a particular sample size. The error in estimation is a mean square error as shown there, which is about an 8% standard deviation. And on average, out of the number of patients treated, about 94 will be treated successfully. Remember, the ones that would get allocated to arm 4 are going to do better on average than those that are allocated to the controller arms 1 through 3. In the response adaptive randomization, the power is increased to 82%. The reason that happens is because you shift experimental patients from lesser performing arms to better performing arms, so you get a bigger difference between the 2 groups. It's easier to pick up. The probability of getting the right arm is better. It's about almost 60%. And in fact, your accuracy in estimating the treatment effect of the best arm, the one you're going to recommend for clinical care, is more precise because you've put more patients on that arm. And you also treat patients marginally better within the trial with 4 or 5 expected additional successes. What about the Nugget example, where there's only one of the 4 treatments that works, and you're trying to pick out that nugget out of a collection of 4 experimental arms? In this case, it's hard for the fixed design because it continues to allocate patients to equally to the lesser performing experimental arms. The power is less. The probability of selecting arm 4 as the best is substantially less. The precision in estimating the treatment effect of the selected arm is less for the fixed design, and you treat patients less well within the trial. So this simulation gives you a quantifiable answer to the question of how much better is the design in terms of getting the right answer, estimating the treatment effect, and picking the right arm to pull forward, and how well you treat patients within the trial. So what I've done is I've taken those list of goals and I've ordered them the way I would order them. And the reason there's question marks at the bottom is because the relative importance of treating patients well within a trial versus after a trial depends on the clinical setting. So there isn't a definite order. So now I've reordered them the way I like, and let's talk about what that means in terms of the selection of trial design approach. For the patient-centered goals of efficient evaluation of multiple arms, or better treatment of patients within the trial, or accurate selection of treatment arms, in general, an adaptive design, either an adaptive platform design if there's multiple treatments, or simply use of response adaptive randomization is better. The exception is if you have only 2 arms to evaluate, in which case that is maximally powerful, and you don't get much of an advantage for response adaptive randomization in terms of picking the best arm. For the statistical goals of getting the right answer, of accurate and efficient selection of the best arm, or for estimation of the treatment effect for the best arm, if you only have 2 treatments, balanced randomization is efficient, but if you have more than 2 treatments, RAR is better. There's a number of ethical issues that have been brought up. This is a slide to try to get you to ask me about those afterwards, since the moderator has stepped up to the podium, or is about to step up to the podium. So in conclusion, response adaptive randomization is not better or worse than fixed randomization. It is a tool that can be used to achieve specific goals, and those goals, in my opinion, are goals that are often of interest when conducting clinical research in low and middle income settings. But it's the clarity of the goals that's the prerequisite for the thoughtful discussion about clinical trial design, not the other way around. And the goals should not be considered in isolation, as there are often trade-offs between multiple desirable goals, like accuracy and estimation and effective treatment of patients within the trial, and it's the clinical trial simulation that allows all the stakeholders to be informed quantitatively about the trade-offs that are being considered. Thank you very much.
Thank you. So while I will ask all the other panel members to join us up here, are there specific questions for Roger on his very stimulating talk? And I see Joe as enthusiastic as ever.
Thanks, Catherine. So, for the slow reading among us, what are the ethical issues you see with this type of trial design?
So, I think the ethical issues, I think the first ethical issue is a lack of clarity on the people who are giving input on the trial design. So if we have a clear vision of what it is we're trying to achieve, for example, whether it's a greater priority to treat patients well within the trial or only after the trial, then we can start to communicate transparently about the trade-offs between resource allocation, risks to subjects, and those goals. So I'm actually not trying to be evasive here. I think the ethical challenge is the fact that we are often so conditioned by the paradigm we learned for doing clinical research that we've lost sight of the actual trade-offs that we should be discussing. I think that's the biggest threat.